This is Mark Mahan presenting the Human and Winds chapter on peripheral nerve surgery for the treatment of central nervous system disorders. By way of background, this chapter focuses on reconstructive neurosurgery as an emerging subspecialty within neurosurgery that focuses on surgical procedures in order to restore or reestablish critical functions that are lost through central nervous system injuries. Many of the surgical techniques are borrowed from surgical treatment of peripheral nerve injuries, such as nerve transfers for the treatment of brachial plexus injuries, where there's been resounding success in restoring functions in a better strength and better quality by use of distal nerve transfers than sometimes achieved from primary nerve repair. In essence, these reconstructive neurosurgical options are the novel application of peripheral nerve surgery techniques towards central nervous system injuries. In particular, spinal cord injury, which has shown dramatic improvement in restoring function. When these surgical procedures are successfully applied under appropriate guidelines and criteria for success, these interventions can have immense impact on the independence and quality of life for individuals, oftentimes without the adverse effects or limitations of older techniques such as tendon transfers or osseous fusions. This chapter will also review these nerve surgeries not just for spinal cord injury, but also for spasticity, cervical dystonia, spastic hemiplegia, and brainstem disorders. Spinal cord injury is a vast societal problem, not only for those that it affects, but also for society at large due to the large preponderance as well as its typical effect on young, healthy individuals. For patients with spinal cord injury, their top priorities for rehabilitation focus on reanimation of the upper extremity, particularly hand function, as well as restoring bowel and bladder function. Nerve transfer surgeries allows for the transfer of functions above the level of injury, which are currently under volitional cortical control, to those below the level of the injury, which suffer from a loss of control. Figure 1 illustrates the three distinct pathophysiologic zones of spinal cord injury, with the supralesional segment, which is the healthy spinal cord with appropriate descending motor control and lower motor neuron control of the muscle. In the lesional segment, lower motor neurons are lost due to the trauma and associated edema, which causes a loss of distal innervation. And in the infralesional zone, where loss of upper motor neuron control predominates, but the lower motor neuron is intact. This distinction is important because nerve transfers can be performed to the infralesional zone at any time due to the health of the lower motor neuron and consequently the health of the distal nerve. In contrast, for injuries in the lesional zone, the nerve typically goes under well-described atrophy over time from the injury, and therefore nerve transfers in the lesional zone optimally should be considered early after spinal cord injury to avoid failure. Also, nerve transfers really depends on the availability of the supralesional zone for transfer. Specifically, there's a risk of a deficit from the donor, meaning that when you borrow function from above the level of the injury, it's potential that you decrease strength, as well as that there are enough axons within the supralesional nerve transfer to power the infralesional zone. If the supralesional nerve is not selected carefully and there are too few a number of axons remaining, presumably from partial injury during the spinal cord injury, the transfer will not be successful. In cervical spinal cord injury, functional restoration focuses on functions that will achieve good reanimation of the upper extremity, in particular elbow extension, grasp, pinch, and finger extensions skills. For example, reanimating elbow extension permits greater range of motion of the arm, as well as potential options for wheelchair propulsal and even self-transfers, which provides an individual an incredible measure of independence and autonomy. Meaningful restoration of elbow extension strength has been achieved through transfers to the triceps, often with use of branches of the axillary nerve. Key pinch, arising from thumb and index opposition, can be achieved through transfers to the anterior interosseous nerve, commonly using branches of the musculocutaneous as donors. Additionally, finger extension can often reliably be reestablished through transfer of the supinator branch to the posterior interosseous nerve. In lower spinal cord injury, the nerve transfers have been relatively varied and relatively experimental. For example, there have been attempts to transfer the whole ulnar nerve towards the intercostal nerves to drive lumbar motor nerve roots, which has met with mixed results. More recently, there have been several strategies employed to restore bladder continence using peripheral nerve transfers, such as that provided in Figure 3, where intercostal nerves are transferred to sectioned nerve roots at the sacral level to reestablish continence, which holds potential options in the future for reanimating and achieving bladder continence. Spasticity is a profound consequence of upper motor neuron injury, frequently as a result from stroke, cerebral palsy, multiple sclerosis, and trauma of either the spinal cord or traumatic brain injury. Oral and intrathecal antispasmodic agents often have effect for diffuse spasticity syndromes, but don't achieve reliable control of focal spasticity, and are in particular associated with substantial side effects. Chemodenervation, such as the use of injected botulinum toxin, can be effective for the short-term treatment of spasticity, but when used long-term, do not achieve reliable control, oftentimes from clearance of the botulinum toxin through immune process such as immunoglobulin resistance to the botulinum toxin itself. Selective neurotomies or neurectomies, where a portion of the nerve is trimmed, have shown reliable results for good long-term control of spasticity. For example, selective tibial neurotomy is a well-established surgery for spastic equinovarus positioning of the foot, where patients oftentimes demonstrate substantial improvement in foot positioning, walking endurance, and decreased use of braces or orthoses. It is important to recognize that because only part of the nerve is sectioned, the muscle will be reinnervated over time by collateral sprouting of the motor neurons that are left intact. Cervical dystonia has been treated with selective peripheral denervation of the spinal accessory nerve and posterior cervical ramusectioning. It has had a successful history with multiple recent modifications to achieve a more durable result. However, although results tend to be very successful with this peripheral nerve procedure, more frequently the use of deep brain stimulation has come into play for treatment of cervical dystonia. In 2018, a group out of China published a landmark trial for the use of a contralateral C7 transfer to reestablish function on the hemiparetic side after stroke. The contralateral C7 transfer is a commonly used procedure for devastating brachial plexus injuries, and these authors provided a trial in its use in hemiplegic stroke. While the authors demonstrated good improvement in the paretic side, it is to be recognized that some of the benefit may come from the deinnervation aspects of the procedure. As described previously regarding the peripheral deinnervation for spasticity, sectioning of the nerve root oftentimes decreases spasticity and allows greater control and greater movement from relaxation of spastic muscles. Recently, there has been an increase in the incidence, particularly in children, of a longitudinal extensive gray matter lesion resulting in the setting of a febrile upper respiratory illness, which is known as acute flaccid myelitis. The acute management of AFM remains limited to antiretrovirals, immunomodulators, and steroids, which have shown some measure of success. However, unfortunately, the majority of these patients are left with severe devastating losses and atrophy. Recently, some surgeons have described case series of successful nerve transfer in patients that have been left with devastating losses. And more novel nerve transfers have been applied to provide substantial benefit in this patient population. However, these remain relatively challenging lesions because the lower motor neuron loss can oftentimes be both diffuse and patchy, meaning there can be substantial loss in multiple contiguous myotomes without good suitable donors, as well as some of the donors appear to be strong for the individual, but are oftentimes running on a small subsegment of axons, meaning there are too few axons to provide a meaningful and reliable nerve transfer to reestablish new functions. While this surgical technique is promising, it remains relatively challenging and should be practiced only by those with substantial experience. Nerve transfers have been classically applied for numerous brainstem lesions. For example, we've been treating facial palsy with nerve transfers for over 100 years. The common applications for facial nerve palsy include cross-facial nerve grafting, as well as hypoglossal nerve transfers. However, due to the morbidity from a hypoglossal nerve transfer, there's been increasing emphasis in reliability of use of the masseter nerve transfer to reestablish facial function. Similarly, nerve lesions such as the spinal accessory nerve can be repaired from brachial plexus transfers to reestablish control of the trapezius muscle. In summary, there are an extensive amount of neurosurgical procedure that harness the natural regenerative power of the peripheral nerve system to reanimate targets after central nervous system disorders. For spinal cord injury, transfers from the supralesional zone to the infralesional zone can be performed at any time to reestablish cortical control of functions in the appropriately selected patient. There have been substantial, well worked out nerve transfer procedures that target key movements of the upper extremity, such as for elbow extension, pinch and grasp, as well as release. And have provided substantial return of function for individuals. Treatment of disabling spasticity, in particular after stroke or other brain injuries, has been successfully achieved with selective peripheral neurotomies, which can impressively increase patients' walking endurance or use of an upper extremity from release from spasticity. However, some peripheral nerve procedures for treatment of cervical dystonia have fallen out of favor by more recent treatments such as deep brain stimulation. The field continues to evolve, and recent investigations in use of peripheral nerve surgery such as contralateral C7 transfer for spastic hemiplegia after stroke have shown promise, as well as those surgical options for treatment of acute flaccid myelitis. These are oftentimes complex scenarios requiring judicious use of surgery to employ a successful reestablishment of key functions for individuals. Thank you. Here are some selected references of high yield that may be of benefit for the inquisitive reader.